Good morning again. My second talk is on subsolid nodules. After the diffuse ground glass, I chose to talk about the focal ground glass. And what about the CT evaluation? So again, some definitions. Ground glass opacity is an opacity which does not obscure the underlying vessels. And we have in fact two different categories of subsolid nodules, those that are purely ground glass lesions and those which contain a solid component associated with ground glass. And it's important to distinguish between those two categories. Non-solid or pure ground glass opacity, as shown here and here, and part solid or also called mixed GGO in the left upper lobe here and in the right upper lobe here. These two categories can coexist in the same patient. This patient has a part solid nodule here in his left upper lung, and also here pure ground glass nodule, and you will notice that the patients are previously right upper lobectomy. And sometimes these lesions are multiple. Here in this patient who's a heavy smoker, there are numerous subsolid nodules. This one is the largest one. It is nearly solid, but there are also numerous pure ground glass nodules, and the patient has also centrilobular emphysema. So what about the frequency? In the general population, we don't know exactly how frequent these nodules are, but we can say from our daily practice that it's quite frequent, and we don't know if we have currently a true augmentation due to light cigarette smoking, or if we detect these lesions better now that routinely we have millimetric slices for our CT acquisitions. But we have some data from the lung cancer nodule CT screening studies, especially from the Nelson study. The frequency was 7.4% of participants having subsolid nodules, partly mixed GGO or pure ground glass. It's important when we evaluate these lesions to make the difference with false images and also with transient images. This was described as a subsolid nodule, but if we take into consideration the coronal reformation, we can see that this image was only created by this subsegmental atelectasis. And so we need to be sure that it is really a true ground glass nodule in two different orthogonal reformations. This is here another example. It's not a ground glass nodule, it is atelectasis. And in this patient, it's interesting because we have the two abnormalities. This is here a ground glass opacification, and here also with a solid component. And on the coronal reformation, we can see that this is nothing, just a compression of the lung by the aorta, whereas here, this is a true subsolid lesion, and it's a part solid nodule. Sometimes it's not necessary to worry about these images, but because they will spontaneously resolve. That was the case here for this subsolid nodule. Under 3 months follow-up, nothing more. And so it's important to re-evaluate these subsolid nodules to see if they show spontaneous resolution. There are factors that are predictive of spontaneous resolution. It's the fact that we have a large solid component in a part solid nodule, ill-defined borders, young patient age, or blood eosinophilia. But since we cannot be sure if it's going to resolve or not, we have no choice than doing a follow-up CT. This is a part solid nodule with a large solid component, and you can see that on the follow-up CT the lesion has decreased, and finally it's only a small scar 3 months later. This is a patient, very young patient, with these 2 lesions, and on the follow-up CT nothing more. So what about the CT acquisition protocol now? Very simple. We don't need any contrast administration. We need to have thin slices, and it's important to read source images and not MIP images. Indeed, this is here an example of a MIP reformation, and you will maybe agree with me that the subsolid nodule in this patient is quite difficult to detect as compared with the source image, and it is obscured by the MIP reformation. So we need to read source images. Now, what about the etiologies of persisting subsolid nodules? Rarely it's focal fibrosis, deep or mild lymphoma. Most of the time, these persisting subsolid nodules represent lung adenocarcinoma at various stages of development, from alveolar hyperplasia to in situ lesion, and then invasive adenocarcinoma. And to distinguish between these different entities, there are 2 very simple criteria. The first one is the size of the nodule, and I will comment these 2 papers, very important. The first one is from Dr. Nakata. It's an old paper, but very useful, I think. What he reported is that above 1 centimeter, a persisting subsolid nodule is at least in situ carcinoma. And the second paper I would like you to remind of is this recent paper for Dr. Lim, who suggested a cutoff value of 16 millimeter for differentiating in situ from invasive adenocarcinoma for pure ground glass nodules. So first criterion is the size, and the second is the density or attenuation, and usually there's a good correlation between the fact that there is a solid portion, usually representing invasive component, whereas the ground glass is, corresponds to lipidic growth, to in situ adenocarcinoma. We have a cell proliferation along the alveolar walls. The solid portion is not always due to an invasive component. In this patient, it was not with a part solid nodule. It was due to alveolar collapse, and in fact, it depends on the size of the solid component. In this very recent paper, you will appreciate that I made recent literature research for the talk. A size above 5 millimeter at 100% sensitivity for an invasive component. In fact, I like that topic because we have very good correlation between our images and the histopathologic data. If we consider the revised classification of lung adenocarcinoma, it was done in 2011, and the CT feature, you will agree that we have good correlations. In situ adenocarcinoma should be pure ground glass lesions less than 3 centimeter. Minimally invasive adenocarcinoma are ground glass lesions with solid component less than 5 millimeter. Predominant lipidic lesions are part solid lesions with solid component above 5 millimeter, and this fourth entity is invasive mucinous adenocarcinoma formerly mucinous bronchoalveolar cell carcinoma, and with these lesions, the CT appearance can be very different, from consolidation with air bronchograms to solid lesion or part-solid nodules. It depends on the patients. And lastly, acinar, papillar, micropapillary, and solid lesions are characterized on CT by a solid lesion, sometimes with ground glass, but which is usually very small portion. This is a patient with an invasive mucinous adenocarcinoma, with here a consolidation and distally numerous subsolid lesions. It's very important to mention that these subsolid nodules, even though they are lung cancer, lung adenocarcinoma, are slow-growing tumors. And these are many consequences. This very old publication from Dr. Azegawa reported mean doubling time of 813 days for pure GTO and 457 days for part-solid nodule, whereas for solid tumors it's around 150 days. So if we have this in mind, you will agree that a 6 months or even a 1 year stability does not guarantee the lesion is benign, and it's very important to always compare on 2 follow-up CTs with the oldest previous CT that we can analyze. And what about the growth criteria? It should be a diameter increase of at least 2 millimeters, or the development or increase of a solid portion in a previously pure ground glass nodule. There are also radiologists that use the concept of mass, which is the attenuation and multiplied by the volume, but we need to have a dedicated software to evaluate the mass. And this is this is an example of a patient with a subsolid nodule. Initially, it's a pure ground glass nodule, and then a solid component develops posteriorly. And as I mentioned, it's very important to compare not 2004 with 2003, because there are very little differences, but you need to compare the 2004 CT examination with the first CT examination, and it's obvious that the nodule has increased in size and that a solid component develops. And the very frequent mistake is to just use the previous CT and to say, okay, nothing has changed. No, we need to get the first CT evaluation that we can have. And when the solid component is small, the doubling time is very long. Here it was nearly 3 years. And as the solid component, which represents the invasive part of the carcinoma, increases, the doubling time is shorter. It's now only 2 years. It's still a long doubling time, but it shows that the lesion is going to become more aggressive. So this is here an example of a patient with a subsolid nodule of the left lower lung. And 1 year later, we need to say that the lesion is growing, the solid component has increased, and it represents an invasive adenocarcinoma. No need to continue with follow-up, we need to take a decision. In this example, there is no significant change. We need to consider at least a 2 millimeter difference in diameter. It was 9.1 and then 10.6. It's just the inaccuracy of our measurements, and the lesion is very stable. It's a pure ground glass, and nothing has changed within this 20 months interval. Here, the nodule has grown from 11 to 16 millimeter, but it's in a 6-year interval. So these lesions are very indolent. And to perform the measurement, we should have a very precise protocol and to zoom on the lesion to perform the measurements. And this is another example. This patient was operated for this aggressive lung adenocarcinoma, manifesting as a speculated solid nodule, and we neglected this subsolid nodule, and I think that it was a good decision because 6 years later the patient has still the subsolid nodule, and she's been treated surgically successfully for her lung cancer. PET is definitely useless for evaluating subsolid nodules. They're usually not FDG avid. The only interest could be to detect a mediastinal lymph node invasion, but there is no risk of mediastinal lymph node involvement for pure GGO lesions, and it's only a risk for subsolid nodules with at least 50% solid component, but even in this situation, PET accuracy is insufficient, so forget PET for subsolid nodules. What about the role of the percutaneous core biopsy? I would say that we have less diagnostic procedures than for solid lesions, and that the complication rate is higher, and that the role is a matter of debate, because we know these lesions are lung adenocarcinomas, and maybe the current role is to have the mutation status in patients that we are not going to treat surgically. Or to convince a patient to be operated, could be another reason to do the biopsy. This patient had been followed up for 3 years, and each radiological report was okay, the lesion is stable. And so when he came to our institution and I reported it as a lung cancer, he was not convinced he had a lung cancer, and so I did the biopsy just to convince him that he should be operated on, and then he accepted to have a right lower lobectomy. I don't know if you heard about this new thing, the lung RAD thing, and it's interesting to see that lesions that are considered as 4A or 4B are only part solid nodules. You can have the whole information through this website of the American Association, and lesions that are considered as definitely malignant are part solid nodule with solid components over 8 millimeter. So in conclusion, subsolid nodule diagnosis is very easy. They will either spontaneously resolve or they correspond to a lung adenocarcinoma. So it's very easy. What is more difficult is how we should manage this indolent lesion. It depends on the patient. It's not the same decision in an 80-year-old patient and in a young patient. And if we decide to perform a CT follow-up, it should be annual. It's no need to re-evaluate this indolent lesion every 3 months. 1 year follow-up is enough. And it's important to detect if a solid component develops in a previously pure ground glass nodule or increases, or if the nodule enlarges, and again, remember that the significant difference should be at least 2 millimeter. And it's important to mention that there are currently many researches on alternatives to lobectomy. such as segmentectomy or alternative to surgical treatment with stereotactic radiotherapy or radiofrequency ablation. And finally, some take-home messages. Remember to compare the CT with the oldest previous CT that you can get, and regarding the growth criteria, consider at least 2 millimeter change as significant, or the development or increase of a solid component. Thank you for your attention. I think that we have time for questions. Yes?
When you say that a large solid component is a relatively better indicator of possible spontaneous resolution, is there a guideline for how large is large, occupying 75% of the lesion or some other amount?
No, it's not my personal opinion. It was just indicated in that paper from I don't remember the author, Dr. Lee, but he mainly recommended to perform the CT follow-up. So there are no strong criteria allowing to avoid performing a follow-up CT. But maybe it's to tell the patient not to worry waiting for the follow-up CT.
If you have only a pure ground glass nodule, would you follow up to the moment where you find a solid component, or do you let it operate if it can enlarge it?
In a previously pure ground glass, the development of a solid component theoretically indicates the need for treatment. But it depends on the patient condition, and this is the point where the guidelines are quite difficult to summarize, because it's not the same decision depending on the patient's age and comorbidities. But definitely, if a patient is free of comorbidities and is young, the development of a solid component is an indication for resection, for surgical resection.
So the corollary is, if there is no solid component, you will never operate.
Yes. Yes, but again, it's a matter of debate. For some authors, it's true if the lesion is less than 3 centimeters, and for others, there's a cutoff between, for pure ground glass, above 16 millimeter, it can be a minimally invasive adenocarcinoma. But, for instance, in the Nelson study, a pure ground glass nodule, whatever its size, is considered to be a negative screening. And it's also true that if we do very long-term follow-up, a pure ground glass lesion can transform within 10 years. So my opinion is that maybe we should destroy that lesion in a young patient, but without surgery. Maybe stereotactic radiotherapy would avoid the transformation 10 years later in an invasive adenocarcinoma. But it's my opinion, it's not a guideline. It's true that if you have a pure ground glass lesion, you should not interrupt follow-up. And so it's quite a decision in a 50-year-old person to decide that each year for 10, 20, 30 years, the person is going to have a follow-up CT.